So now we're going to talk about rapid sequence intubation, something that we're all expert at. So why do we paralyze patients? If we predict they're going to be difficult, why do we use a paralytic?
Well, you need maximal relaxation of the body, both the jaw and your ability to get your axes all in line.
Absolutely. So we know that it gives us the best possible conditions for laryngoscopy if they're paralyzed. So what else does it do? It also allows us to more effectively bag a patient. So ventilating a paralyzed patient with a bag valve mask is much easier than the spontaneously breathing patient. Everyone's probably experienced that. Trying to bag somebody that's breathing erratically, it's very difficult. So what's our first go-to if we can't get the tube? We bag the patient, right? Take the tube, I can't see the cords, tube comes out and we start bagging the patient. So that's our first rescue device. And so to optimize that, we want the patient paralyzed. And there's even a study in anesthesia. There's a 67% improvement in ventilation, not 60, not 70, but a 67% improvement according to this one study. So what's the other thing we do if we get in trouble? If we can't intubate, we talked about it in the rescue devices. What's a rescue device we use? An LMA or a King LTD. So can you use an LMA or a King LTD on an awake patient? No. Anyone says yes, we'll try it right now. So no. So they have to be paralyzed for us to effectively use these rescue devices. And so what I'm leading you down the road is the safest thing for the patient is to stay paralyzed once we paralyze them so we can bag them effectively, so we can use the supraglottic devices and they're not waking up while we're trying to manage their airway. Okay, so failed airway again is after 3 attempts, and paralysis is necessary to get into that rescue device. If they're waking up, that's just not an option for us. Okay, so Mike, how good are we at RSI in emergency medicine? So for medical patients, what percentage of patients do you think we successfully intubate in emergency medicine using RSI? 75, 80%. 80? Okay, anyone else?
99.
99? I guess the slide is there right there. So we're incredibly good. We're almost perfect with medical patients. And that's why we're so unfamiliar with surgical airways, because most of us have never needed to do it because we've been successful. So 97% in trauma patients. And what are some complications from RSI? So like, think about if you're supervising a resident, what can they screw up?
Lacerations of oral pharynx, banging up teeth.
Yeah. I had a resident completely knock a teeth loose last week. I've never seen that before. So, and then we couldn't find the dental box. So yeah, tooth. What's the most feared complication?
Tube of the goose.
Right, esophageal intubation. Right. So 3%. Most of these are cosmetic, except of course for the esophageal intubation. Basically, how do we tell? How do we know if patients are going to be predicted difficult or not difficult? Because our algorithm is going to be completely different. And what I'm telling you is even at trauma centers with a trauma surgeon sitting there jumping up and down wanting to go to CAT scan, that it may be appropriate to do sedated intubation on high-risk trauma patients rather than paralyzing and just hoping for the best. Okay, so this evaluation of the airway is a safety net. It's a safety net for the patient, most importantly, but it's also a safety net for you to show that you had a deliberate approach to the airway, you thought about it, you considered it, and you came up with this plan. The plan works, the plan doesn't work, but you thought about it. And again, we want to avoid this scenario where you can't intubate and you can't ventilate and you've got to draw the knife. So there's 2 questions we need to ask. The first one, is this patient going to be difficult to bag? Because that's the first place we're going to go if we can't get the tube. And the second question is, are they going to be difficult to pass the ET tube? So let's start with who's difficult to bag. So I'm thinking this guy's going to be difficult to bag. So let's talk about bag valve mask ventilation. Which of you thinks that the procedure on the right is more difficult than the procedure on the left? So, okay, how about the other way around? Who thinks bag valve mask ventilation is more difficult than intubation? Yeah, I do too. And I see physicians do it wrong. I see RTs do it wrong. I see nurses do it wrong. Deb, what's the most common cause of airway obstruction? The tongue, right. Good, Deb. So the technique that most people use is this pressure downward on the oropharynx to get the seal. They're pushing down to get a seal. Yeah, they're pulling up a little bit. Mostly they're pushing down. And what that's doing is just transferring that energy basically to the posterior pharynx and making the airway obstruction worse. You're basically closing off the airway with that downward pressure. And the secret to effective bag valve mask ventilation is essentially hover the mask over the patient and lift their face up into it. Pull their face up into the bag. Now you're pulling the tongue forward, you're pulling the airway forward, and you're getting a good seal, and you're going to be able to ventilate effectively. The other thing that I want you to think about is that whenever this comes out, every single time, 100% of the time, either a nasopharyngeal airway goes in or an oropharyngeal airway goes in. Every single time, use the bag valve mask. Now, how many of you have a set of oropharyngeal airways in every single ED room, including your pelvic room? Well, I did at Reading. What's wrong with you guys? All right, how about in your resuscitation rooms? Okay, so pretty much, but you know, the patients don't slow burn in your resuscitation rooms. Usually it's the back room where they start to crump. So this is my recommendation when you get back to your site. Go to whoever buys stuff at your place and say, look, we need a set of oral airways and nasal airways in every single room in the department, because that way, somebody starts to crump in room number 54, you can basically put something in and bag them effectively while you're moving them to resources or moving resources to them.